have this as a discussion. So, all right. So, is once again, I want to say I'm not going to be telling you all, okay, so ischemic heart disease, it has this and it starts with chest pain. Those are just obvious theory. So I'm just going to brush through some of the important things that you all think. I mean, I think that you all have to remember. So ischemic heart disease, you can always divide it into stable angina and acute coronary syndrome. These are basics. So one thing, like I'm also gonna share some things that how I remembered for the exam. So I just remembered stable angina as stable at rest. So so it's like a that's how I remembered for my exam. So stable angina and acute coronary syndrome, you have that. You can divide the ischemic heart disease into those two. And then acute coronary syndrome can also be divided into unstable angina, non-ST elevated myocardial infarction, ST elevated myocardial infarction, and left bundle branch block. So that's like a basic classification you could do. So along with my little set of slides, I'll be just showing you all how I did things with John Montage. Uh, oh yes, so we have the chat shared there as well. So, so I'll just show you all. This is my John Montage book. I mean, I didn't have it as a hard copy. I couldn't find it. So what I did was I downloaded it to my studying device, which is my iPad. You can have it in your phone or laptop or anywhere. So I had I had bookmarked all the important topics, and this is like basically chest pain. So as you can see, it has very important, short notes. It makes it very easy to remember things this way. So I would really suggest you all to try to download John Montage 8th edition and try to read these topics from that. So in these slides, I have added, so John Montage 426 page is where I got the base of these things. So this is that chapter. So these are some of the red flags that you have to remember in acute chest pain, dizziness, pain on heavy or heaviness, like a thoracic back pain, if there's like radiating back pain, sweating, palpitation, all these things are like, I'm not going to waste time actually on these. You all can read these things. I'll try to share the book. It's quite big. I'll try to get that to my phone and share it on the WhatsApp group so you all can have it as well. So, yeah, that is myocardial infarction. So, yeah. So, now one thing I want to say about AMC is they are not going to ask you what is a symptom of acute coronary syndrome and obviously give you chest pain and all sorts of other clinical features. They are very good at asking these specific points, like what is the number one risk factor for acute coronary syndrome? And I'm sure all of y'all would know like 101. Y'all could just list down at least 10 risk factors for acute coronary syndrome. But AMC is so good at targeting this number one. What is the most? What is the best? What is the most common? They are so good at targeting that question. So always these are the points that we forget to write down in our notes. So don't we always tend to write, okay, acute coronary syndrome. I'm going to be writing the clinical features. I'm going to be writing the what do you call the diagnostic methods, and then I'll write the treatment. No, that's why I told you AMC is a very targeted exam. Know what they're asking. So points like this are very easy to slip. So don't forget to include them into your notes. You'll realize it while doing questions. So remember this number one risk for acute coronary syndrome would be hyperlipidemia. And then we go to investigations. So obviously we'll do a ECG and then we do a troponin, and then we remember if it's normal, you'll repeat after 30 to 60 minutes. We first repeat the troponin, then do the ECG. So that's something to remember when it comes to investigations. And now, so we'll get into the management. So this is again something I remembered for my exam. I hope it'll help you all as well. So when it comes to STEMI, you can remember the order as Mona, and non-STEMI, you can remember it as Ona. So like, I mean, logically thinking, I just thought in STEMI, the pain is going to be like super intense. Like, dude, I mean, you all know it's a complete occlusion, it's a complete block. So logically think morphine should come first to rapidly relieve that pain, like to relieve the pain, the anxiety, and then to reduce the sympathetic drive, right? So just think the patient is in severe pain. You have to first calm the heart first. So once that's settled, you can give oxygen, nitrates, and it's safe to improve perfusion, and you can slowly follow by aspirin. So that's how I remembered Mona for this order: morphine, oxygen, nitroglycerin, and aspirin. That order for STEMI, that's how I remembered. And then for non-STEMI, you could remember that's a partial occlusion. It's not a full blockage. So the goal is to optimize the oxygen supply before touching preload and afterload. So giving too much morphine, like before, I mean, giving morphine too early can cause hypertension and bradycardia, and like it could even mask this worsening pain, right? So what we do in this situation is we give oxygen first, then improve perfusion with nitrates, and then you can start antiplatelet therapy, and then you can give like morphine if the patient is still in pain. So in this case, what I think is the patient is stable. So we support the heart first. So you can remember these two uh, little Mona and Onam things to remember the order. I hope it will be helpful. So likewise, and oh, this one. This word, gold standard, is again a gold standard word in AMC. They try to ask that, sorry. Okay. So they try to ask that quite a lot. So I think it's always good while making your notes to, open up a little book or like a little, I don't know, a separate section to write gold standards in AMC. So maybe if you start studying with cardiology, maybe you can start writing gold standards for cardiology and write like this and that. So remember, the gold standard treatment, the management would be PCI. So, I mean, I know these things, you do it in order, but then if they asked gold standard, now this is where we get things wrong. It could, I mean, the question stem would look like a STEMI, and then all of a sudden you'll remember, okay, so in the discussion we spoke about Mona, let's go for morphine. No, if the STEM asks what's the gold standard, you skip all of these things and then you go to PCI. You select the answer PCI. These are the places where we get things wrong because we are in a rush. We think we have to finish the question in 1 minute. So always try to, like, in your head, try to highlight words like gold standard, try to highlight words like number one risk, not just risk, number one risk. Words like most common, those things are very important when you're trying to, dissect a question and try to find an answer. So gold standard would be PCI, and AMC is also very funny with this. They jumble, I mean, they use synonyms and try to see if we actually know. Actually, this happened to me while doing practicing questions as well. So I added to my note, even if they ask catheterization, angioplasty, angiography, whatsoever, just select that answer. That's how I remembered for that. And another thing is that if a tertiary hospital is not around in less than 3 hours, within 30 minutes of patient's arrival, you have to go for thrombolysis. And now this is a very, what do you say? This is a very serious decision-making situation because once you go for thrombolysis, it's not reversible. So you have this decision is made by the cardiologist. So now see, when it comes to cardiology, you wouldn't even think questions like this would come up in your AMC cardiology section, right? But then those are the type of questions they try to ask us. So maybe they give you a question like a situation where a patient has come, typical MI symptoms are there in the question stem, and then now they're also slowly mentioning here and there in the question that the closest tertiary hospital, like whatever the hospital is not, it's far away, 5 or 6 hours away, and this and that. So now you are also ready to go and answer saying thrombolysis, but the question they're asking is who you're the, let's say, house officer of this ward, and you get this patient, whom would you ask? Whom would you go for the decision making? See, these are the type of questions that we wouldn't even dream of expecting in a theory-based exam, right? But you should know that AMC also wants us to know about these type of little things that they expect us to know. So things like this, in such serious situations like this, the decision is made by the cardiologist. Just know simple things like that. When you do questions, when you purchase Q banks and when you start doing a lot of questions, you will realize that they do ask questions like this. So yeah, that is that. And yeah, I think pretty much all of y'all must be knowing these things. For further management, if they are, these are quite basic. So you just remember you can give aspirin, you can give clopidogrel, beta blockers, ACE inhibitors, statins, and anticoagulants. Those things are for further reading. And I would suggest you all to read this in John Murtagh, 8th edition book. It's in the chest pain chapter. Try to read all these important points, maybe the red flags of acute chest pain. Um, Try to read the investigations. Myocardial ischemia. It's not that you have to read them word to word, but just have a quick go through and read. Try to point out, go through the clinical features and investigations when you're doing that. So, yeah, that should be it from those things. Yeah, these are pretty much the things I just told. So, yeah, okay. So this is something that has been commonly asking, asked throughout the years, these post-MI complications. So you don't have to write paragraphs and paragraphs in your note. Just try to keep them simple and short. Maybe just through tables like this or just flow charts or whatsoever that helps you. So this is something that helped me. So I made this table for me to remember. You just remember time after MI. If it's like very immediate, like 0 to 24 hours, and then the clinicals are like arrhythmic, and if the ECG is showing arrhythmia signs and all that, it could be an arrhythmia. So remember, I told you they are very good at asking the most common complication, most common things. So if you were asked the most common complication of MI, you should select arrhythmia. And now see, that could mislead you, and they could also ask most common cause of death in MI. Then you have to choose atrial fibrillation. So these are the points where you have to I don't know, just memorize in your minds, in your heads, in your notes. Once you go to them frequently, go back to those notes frequently, you'll just remember these points. But these points you can't just leave behind. You have to take them with you to the exam. So that was that. And then we have 24 to 48 hours after MI. If the chest pain is coming again, it could be a reinfarction. So you can do a CKMB and management would be aspirin. And then there's 3 to 5 days after MI, and the clinicals are like murmur. It could be papillary muscle rupture or mitral regurgitation. You got to do an urgent echo, and then the management would be surgical repair. And let's say it's 5 to 7 days after, and then the patient has fever, and then there's pain on line. It could be pericarditis. We'll talk about pericarditis towards the end, very end of this today's discussion. So, apart from that, we also have 1 week after an MI, and if the patient is present with edema and breathlessness, it could be left heart failure. And we also have 2 weeks, 2 weeks, and even it could just lead up to months even. So I found it as 2 to 10 weeks. Just do a little reading and try to find out how far. And if the patient comes with low-grade fever, pleuritic chest pain, and pericardial rub, it could be Dressler's syndrome, and you can go with these medications for that. So if you want, take a screenshot of this or just try to search post MI complications and type RACGP. If anybody forgot that, that's RACGP. This is my go-to guideline for all sorts of medicine related things. So I would just type post MI complications and RACGP and read the articles and update my notes. So I mean, if there's any doubts for y'all along the way, think confusion, always go to John Mutaj or RACGP and try to find things. So that is that. And then let's get to arrhythmias. Um, so arrhythmia is again in John Mutaj, page 854. So let's try to go to that. Yeah, so basically, I have highlighted all throughout my John Mutaj book for all the subtopics like respiratory and cardiology, GI, all those things. My main theory base was John Mutaj, I would say. And then apart from that, all those confusing little points, the places where I wanted like a solid specific answer, I would just depend on guidelines. So just give me a minute. It was what I thought. Uh, it was- Yep. So that is palpitations. So again, I would say have a good read through all of these things. Um, I mean, I think I will have to share the book on the WhatsApp group so y'all can have a copy of John Mutaj 8th edition. So for anybody who can't have the hard copy, y'all can maybe have this book and search it up. So these things are very important when it comes to AMC. Red flags. Red flags are one of the very important things because I'll tell you, they're not going to be asking you as what is a red flag in palpitation, but they will include red flags in a patient and give it to you as a question, like a clinical case, the patient who has red flags. That way, this is no joke. I mean, this is something you have to take serious. Likewise, that's why I tried to let's say, study or remember most of the red flags in all these situations. So, lightheadedness, family history of sudden death, those things just have a read through. Mm, yeah. So, arrhythmias, yeah. So, you all can always have a read through all of these information from the John Montage book, but I have just made a very short this thing. I mean, it's not that all these little things are very important, especially let's say these five or four, the first few will be important, and in this again, this hard block parts were important. Other than that, these uh, other Torsades, day pointers, Wolf Parkinson, White syndrome, those things, maximum you would get like an ECG and you would know what that he is. But apart from that, lot of questions would come from arrhythmia, especially these ones, the common ones. So what I did was in my note, I just divided SVT and VT as a table. And I remember I would write this has this doesn't have that. This has less than 50 years. I mean, more common in less than 50 years. This is more common in more than 50 years. And in this HR is heart rate is more than 200, this one less than 200. And then obviously narrow QRS, this has wide QRS. So that way I would just try to compare, right? So comparing is another tip for note making. It really helps. And because I mean, you wouldn't be getting a straightforward question directing you towards your answer, right? So MC would always try to take the question so much towards SVT and then boom, it'll drop you to, I mean, give you a point where it is clearly VT. So likewise, always know how to compare things. That way you know. So this would, the first one, I'm just going to go through. It's supraventricular tachycardia. Uh, Clinical features, you'll have palpitation. Like I said, these 3 points, if you can remember, especially these two, if you can remember, it'll be very helpful to differentiate it from ventricular tachycardia. So remember, more in young as in less than 50, and then also heart rate would be very high, more than 200. And then as you can see in this picture, it's narrow QRS complexes you would see in the ECG. And yeah, for management, John Montage says vagal manual, and some say the carotid massage is not being used. I mean, I kind of saw it in a guideline recently, but it's always better to read more and see. So I'm not going to say the carotid massage word. We'll just use vagal manual. And then we can go for medications such as adenosine and verapamil. So I will show you guys a table that was so important that I had to print it and paste it right in front of my study table. You know, this medicine and the contraindicated situations where to know when to use this drug and when not to use it. So always remember AMC would give a question like a child coming with a history of asthma and having like a clear cut supraventricular tachycardic ECG. And then they might even say they tried vagal manu or whatsoever. And then they would give you what would you do next? And the first answer option, they would just give adenosine. And then right in your mind, you would just remember your note, knowing that, okay, adenosine was for supraventricular, and you would just go so this is why those kind of it's important to remember the tables where those little tables like in John Mutaj here and there. Let me see if I can find it. Mm, is it, this one? No, this is also a very important table, the summary of treatment of arrhythmias, but this is not the table I'm talking about. Let me see. I will definitely share the John Montage book on the group. And I'll also try to share these important tables, screenshots of them at least, so that y'all can add them into your file. I remember Dr. Shahani the other day, she was saying at the orientation program how she had a little folder in her phone notes with all sorts of tables and screenshots from guidelines and books and just quick things that you find on group chats and all sorts. So I think it's, if you're not the person who has time to sit down and write notes, I also think it's important to have a little note collection like that in your phone wherever you go. When you're having a minute, you can go back to and then have a look at it. So, wait, let me try to find this very important table. I mean, I wouldn't just let go of it if it wasn't this important. Okay, so along the way, I'll try to find it, maybe in a break, and then I'll show you. It had all those, it was compared what drug to take. It's all right. I'm sure along the way we'll find it in somewhere. So yeah, I'm sure. One thing I don't like about John Mutaj is I know it's very clear and cut, but then they haven't divided the topics like myocardial infarction. And so, I mean, it says like chest pain, cough. So you had to like see now this is cough. Like all the differentials of cough are discussed under this topic. So that is one thing that they could have been better in John Montage, but like let's try to compromise with what we have. So yeah, that's a very important table that we got to come back to. I'll try to find it and share it on the group. So that was it about the ventricular tachycardia. Mm, See, you don't have to know very deep into that topic. Just know the basic points. I'll tell you why. I mean, especially when we are doing questions next week, I mean, this week, Saturday, you'll realize that you're not going to remember the deep details, but you'll remember the small little points that we discussed and try to solve questions faster that way. So this is again ventricular tachycardia. Like I said, opposite from that, these 2 points. That's how I remembered. This is more common in older, like it's more than 50-year-old patients, and in this HR could be less than 200, and also patients could have a pre-existing cardiac problem in ventricular tachycardia patients. And just look at the ECG; it's very wide compared to this. When you compare this with this, it has very wide QRS complexes. So in this, for management, you would give amiodarone or beta blockers. Again, always know the contraindications of beta blockers so that you know when not to give things like that. And in ventricular tachycardia, if a child is present with ventricular tachycardia, in Australian guidelines, I've seen they first give adenosine and then give amiodarone. This should be an arrow actually. So they would give adenosine first and then give amiodarone. This is for children. But the place where we gave adenosine first straight away was supraventricular. That was for adults. So obvious ECGs, that is that. Just remember wide and narrow. You'll remember the rest eventually. So next we'll go to atrial fibrillation. So in atrial fibrillation, you have typical clinical symptoms like palpitation, irregular pulse, lightheadedness for a long time associated. I mean, the patient could be presented with an associated thyroid problem. Sometimes the patient could also not have a tachycardic situation. So it's again with the ECG, that's how you confirm things. You can see there's no P wave, and also you can see it's irregularly irregular. I know, like it's not even regular. So that is one thing to remember in atrial fibrillation, and it's pretty disorganized if you quite look at the ECG. So what you would do in atrial fibrillation is you try to control the rate. You could give a beta blocker or a verapamil, or you could just go with digoxin as well. So these arrhythmias, I would say, rather than remembering all these pinpoint clinical features, try to remember the ECG points. I feel like that's the best way to, to uh, ace these arrhythmic questions. So, because it's quite clear cut when you see the ECG. So, next we have atrial flutter. Again, in this, it's a very high heart rate. Nearly it could go up to 300 beats per minute. And then in the history, there could be a long-standing hypertension or like a history of antihypertensive drugs. And then it's obviously presented with palpitation. So I specifically chose this photo to show the sawtooth, show the sawtooth appearance. So as you can see, it's pretty organized, so much organized than atrial fibrillation. It was disorganized. So that's something to remember. Remember the sawtooth for atrial flutter. That's all I did. Um, Again, you control the rate with beta blockers or verapamil, and you can also give digoxin as well. And now we have ventricular fibrillation. So the patient can be present with loss of consciousness. The patient could be collapsed, and then you can see there's a fibrillating baseline. Like this one, it's like a very, what do you say, very like a, I don't know, for me in my head, ventricular fibrillation gives out a very drastic appearance. It's like a irregular, it's broad and all sorts of these things. So it it just gives me the reminder, okay, just think of ventricular fibrillation now with the clinical features as well. So that's something I've always thought. So this ventricular fibrillation ECG, and the management for this would be DC cardioversion. There's a little another thing I wrote down to remember the management with hemodynamically stable and unstable patients. I think I included it here. We'll discuss that while we are going down. So now this one is something I got from the handbook. So about the handbook, I know I think I said this in the orientation program as well. It's from 2005 or so. It's very old. It's like 20 years old. But in the exam, something I felt like was these ECGs were, I don't know if they were the same, but pretty much similar from the handbook ones. And one of the things, I didn't get this, but one of the things most of the candidates said were that handbook pictures, handbook x-rays, dermatology, these orthopedics and this and that, fractures and that, most of the pictures that appeared in handbook would directly appear in the exam as the picture itself. Like the question would be different, the answers would be obviously different, but if you are obviously not going to study the question and the answer, right? From the handbook, you're not going to memorize this is the answer for this question. So once you see a picture, or once you see what do you say, an ECG or something, you try to remember a little story behind that. Remember a little note behind that. That way you would touch all those topics, right? So that would be beneficial for you at the exam because they still try to, I don't say they don't completely depend on the handbook, but they try to go somewhere close, like go round and round around the handbook. So I Phil would say to prioritize finishing the handbook at least twice before your exam. I mean, that would definitely be my advice because the first time you try to do the handbook section wise, just like this. So, this week is a cardiology week for you all. You go through the theory, you study cardiology from your John montage. You will write little notes. You will do a lot of cardiology questions, and then you will go to your handbook and then do the cardiology questions as well. I mean, now that we came here, I will just quickly go through the handbook. I mean, not go through, I will just show you all. So when you go to the index, obviously, you will find, I think I highlighted. Yeah. So you will find this medicine and surgery part. Those are questions from 3.001 to 3.228. So I think I highlighted so I won't miss it. Yes, so cardiology questions, they start from page, but in the PDF it's 252. So see when you go to medicine and surgery, just if you can make a quick note somewhere, if you can write it down, handbook questions 3.070 to 3.085. So after today's discussion, maybe take tomorrow the whole day to read John Montage, to, do a little theory time, and then try to do these questions. It's about 15 questions you all have there, so try to do them. I mean, even if you get anything wrong, that's fine. You try to read that and do your search again related to that topic, and then you learn something more that way. So yeah, these are the handbook cardiology questions. Try to do them. As you can see, ECGs, I feel like they're pretty much using the same set of pictures for ECGs. I don't know, it's just what I think, but yeah. So that's that. They do also have the answers. So I just added this question to show you how you don't need to know all sorts of everything to solve a simple AMC question. Now see this one. A 62-year-old woman is seen in the ward 24 hours following a non-ST segment elevation myocardial infarction. Announcing. She complains of lightheadedness. The radial pulse rate is difficult to feel, and the blood pressure is very low. Heart sounds are muffled, and there is evidence of biventricular cardiac failure. Which one of the following rhythm strips shown would be of most concern in this situation? So for me, I mean, I'm just trying to take from the question itself. I mean, if you all have an answer, try to put it on the chat. Yeah, try to put it on the chat if you all think of an answer. See, now they are asking what would be of most concern in this situation. They're not directly asking a diagnosis or so. They're asking what would be the most concerning in the situation. For me, when I see a question like this, I would just think of the age of the patient and then having like history of other cardiac diseases would also just highlight for me. Following the non-STEMI has had a history again. So, and also it has to be the most concerning situation out of all of this. So I'm pretty sure with the little discussion we had, you all can name these things what and what. But for it to be the most concerning situation, do we have any answers? All right, so out of these ones, let's just go simply try to find out each ECG type. So what does this show, the QRS? It looks pretty wide to me compared with the rest. So I would think that's a wide QRS. And I would just quickly think of my notes. And I would think, where did I see wide QRS? With the age and the history, it's pretty much like that. So I would just think this is PT. And yeah, so I'm sorry about that. So yeah, so this, again, what would this look like? It looks pretty irregular to me. So I remember talking of a very regular situation up in the discussion, and we thought it's irregularly regular. And so I would call this an AFib. And then I see somewhat of a saw, sawtooth appearance here. Before that, I mean, when you compare A and D, it's pretty much obvious one has wide QRS and one has narrow. So I would think D is narrow QRS. So that would be my SVT. And I mean, forget about the degree, but I mean, we didn't discuss that yet. This is pretty much a hard block. So this looks sawtooth to me, sawtooth appearance. So we discussed sawtooth would be atrial flutter. So I would just quickly, when I say ECGs, I would just go through and instead of seeing them as ECG strips, in my head, I would see them as answers. Answer one, VT, answer two, AFib, three, flutter, SVT, and five is hard block likewise. So that makes it easier for me uh, rather than going, I mean, deciding until the last minute if is it actually flutter or is it actually SVT? So that will take time until the last minute. So what I would do is I would quickly diagnose the ECGs like this and maybe write it on the paper that's given. So yeah. So what I want, why I use this question here was to show that from our little note, I know it doesn't have lots of information, but it did have. So the answer for this question is ventricular tachycardia. So in our discussion up there, I told you I divided in a table and I was making my note for SVT and VT. And then I wrote SVT, I would see in 50 years old below, this 50 years old above. And I remember I had a point called pre-existing cardiac diseases for this. So just look at the stem. with the STEM, this is how AMC ask. I mean, like, these are the little points you have to make sure you include in your note so that questions like this won't take long for you because you'll just straight away remember things from your note, the points from your note. So that's why I mean we'll do questions more than this this coming Saturday. We'll discuss, but just wanted you all to get an idea on how to include things in your note and how important it is to have little points to remember in your note when you're making them when it comes to questions like this. So, yeah, you can read these through with your handbook, the explanations. I mean, some of the explanations in your handbook is pretty much old, but try to let's say try to get the question. And if you're not sure of any answer that's given in the handbook, always try to search it, always try to reassure it with your own resources, with guidelines, with John Mutaj, or even if you're not sure, just copy paste the question or screenshot it and share it on the WhatsApp group, share it on the webinar group, and maybe somebody else will have like a better insight on that. Maybe others will share guidelines that you haven't even seen. So that's why it's very important to discuss. So yeah, so until this Saturday, try to do as much as cardiology questions as possible. So this is not a topic that you should know into depths, but just remember the delta wave in this. And just maybe you could remember that management in case they give a ECG and ask for management. So for Wolff Parkinson White syndrome, just remember procainamide, amiodarone, or even radioablation, and just the I don't know the best and only way to diagnose this through an ECG would be the delta wave that you would see. And then this was asked once in, I mean, some time ago in AMC. That's why even that's why it was at least a topic to discuss here. So just remember the spindle shape in this, and management would be IV magnesium sulfate. Like I said, they could give the ECG and ask for the treatment method. So that is that. And yes, this is something I just remembered uh, from my notes, and it pretty much helped me decide between these two answers because usually when they ask a question, I mean, I always see DC cardioversion and defibrillation just right next to each other, and there have been so many times where I have kind of like decided what to go with. So little this small note has helped me do so many questions. I mean, solve so many questions. So just remember, if any tachyarrhythmia, the patient is hemodynamically unstable. So in that case, don't expect the question to come up saying a hemodynamically unstable patient is coming, this and that. No way. So in that case, you should know these things. A collapsed patient or like a BP is given 90 to 60 below than that, or the question would say a confused patient. So if these things are there, you could call that patient by your means that it's a hemodynamically unstable patient. That's how you would know this is a hemodynamically unstable patient. I think you will come across this when you're doing a lot of Amadex cardiology questions. We'll try and do as much we can next Saturday, so you'll realize then. So even in that case, you will then quickly check if this patient has pulse or not. So if pulse is present, you would go to DC cardioversion. And if pulse is absent, you would defibrillate this patient. You would go for defibrillation. So that is a very important point there. And you'll see how many questions you can do with just that point. So yeah, we'll just go through the heart block parts as well. I'm sure all of you all know these things, but since these are very common topics in AMC, there's no way we can skip these parts. So first degree heart block, it's pretty much asymptomatic, and there could be a history of using beta blockers, calcium channel blockers, and digoxin in patients with first degree heart block. And it could also be due to aging, cardiomyopathy. So if somebody comes with an ECG like this, and then there's history of all of this, you don't try to treat them, just try to seize the drug that's causing uh, this kind of situation. So just look, it's the basic first degree heart block ECG. And then next we have second degree heart block, which is the more, this is the Mobitz type 1 one. So in this, the main thing that you have to remember again, it's pretty much like the first degree heart block. It also has a similar um, clinical features like history of using beta blockers, calcium channel blockers, and so. But the difference in is in the ECG, you would see the PR interval slowly increasing and then dropping a bit. So likewise, that is, I mean, that is how I remember Morbid. I'm sure that's how you all remember Morbid type 1 as well. Increasing and dropping would be Morbid's 1 in second degree heart block. So basically, just like the first one, you could just stop the offending drug, no specific medication also for this. So, yeah. And then we have the second degree heart block, which is this is the second degree heart blocks, Morbid's type 2 one. In this, you just remember there's, I mean, like PR constant. In this one, the PR was increasing, the PR interval was quite slightly increasing, and then we had a drop. In this one, we have constant PR intervals. Before a QRS, there's a drop. I mean, like missed beat after a few normal beats. That's how I would remember Morbid's type 2 in second degree heart block. And for this, you could have clinical features like syncope and history of previous MI. So for this, you could use a pacemaker. That would be a second degree heart block, Morbid's type 2. And then we are going to complete heart block. This is a third degree heart block. As you can see, there's no relation between P waves and QRS. They are going on their own. They're doing whatever they want. There's no relation, at least there's no rhythm, there's no connection. So in this also, you would see syncope, dizziness, hypotension, and acute heart failure. And yeah, as you can see, atrial and ventricle, they contract completely separately. And then for management, first you can do a temporary pacemaker, and then you could go to a permanent pacemaker. So once again, I'm telling you all, just read through all of these topics. This is like a guidance. This is like a basic, what you call, just trying to show you all a frame through what you all should do your own work through. So I'll be just saying degree, heart block, this, that, arrhythmia. After the lecture, maybe tomorrow, maybe tonight, just sit down and try to write down those topics in a list and try to read each one of them from John Murtaj or RSCGP guidelines. I'm just going to write the name of the guideline one more time. RSCGP guidelines. And even if you don't write down a note, just try to take screenshots or try to remember, I mean, save the links or bookmark them for further reading. So try to do a lot of reading in these topics because I'm just trying to show you all what are the most important topics. And also, I want to say all these things are in John Murtaj as well. Like I said earlier, I'll be sharing the John Murtaj book with you all. Yeah. So digoxin toxicity was once there a differential diagnosis with in an ophthalmology question because it has eye symptoms like visual symptoms. So that's why I just had it in my note. Mm, there's a there's an ECG that you should remember for this. I've forgotten to add it. It has a hockey stick appearance. I'll just try to see if I can. What RSHP? Just try to find a decomposing toxicity picture for that. It's just a hockey stick appearance. I'm sure most of you all must have seen it already. Oh yeah, just remember that. It's like this is the hockey stick we are talking about. So just to remember that. So it's simple. You stop the drug and then you can give sodium bicarbonate. So yeah, that would be that. And that's a pretty basic run through the arrhythmias. When you do questions, you'll realize more areas that you have to remember, and then also you'll just know when you're doing questions, the most important thing is to know the basic thing, and the little important things will come through while doing questions. So yeah, okay, we'll just quickly go through. Yeah, okay, since yeah, I think I did heart failure from the yeah. So heart failure is again, it's very explained in John Montage. So you would find it in page, the PDF page would be 1047. Just read through all these important things, and probably very rarely you'll find classifications asked, but then there are places where classifications are asked. But so this was a important part, drugs that can aggravate chronic heart failure. And I say it's including COX-2 inhibitors, corticosteroids, tricyclic antidepressants, calcium channel blockers. Just read through all these things or take a screenshot if you think it's valuable for you. And then we also have to read the initial therapy for heart failure. I remember having this. Okay, so this is where I was trying to come for. So when you do questions, you'll just realize this stepwise pharmacological management situation, because most of the time in questions they tend to ask what's the first line, what do you start with, or like maybe they in the question they have already started something and they're asking the next. So flow charts come in handy in situations like this. So, I mean, one of the best places to find good flowcharts would be the RSAGP guidelines, just RSAGP pages. So try to find and collect as many flowcharts as possible. And if you don't find flowcharts, make your own. So yeah, this is a very important flowchart when it comes to heart failure. This is something I studied through. So you always start with ACE inhibitors, and then you can, I mean, like just remember ACE inhibitors, and then you can, I mean, give it diuretics. But then one thing to remember in diuretics is diuretics would be first line when like there's fluid overload or acute symptoms are present. That's something I remembered. So only if needed to control fluid overload or symptoms. So it becomes the first line treatment when there's fluid overload or acute symptoms present. Otherwise, remember ACE inhibitors as the first line drug. And then you can add a beta blocker if the patient is stable. And then you could then again add like spironolactone, and then can add digoxin. Likewise, this chart is quite important. Try to remember that. And then yeah, so this is again. And that's pretty. Yeah, I think heart failure note. I mean, the heart failure chapter is not that very long and expansive. So try to read this from the John Mutaj book and try to get the important points. And I would say mainly it's about the treatment in heart failure. They don't ask anything else. They don't just ask what are the symptoms of heart failure and all sorts. They would just give you a typical heart failure situation and then maybe ask for treatment. Uh, we'll figure that out while doing questions next week. So that is that. Now we'll go to murmurs. Even in murmurs, they weren't like very, they didn't ask very deep into murmurs. One thing that you have to crack the code in murmurs is knowing the type of murmur. So these four um, diseases, I mean, these four conditions, let's say aortic regurgitation, mitral stenosis, aortic stenosis, mitral regurgitation, those four were the main ones that were coming up. So the way I cracked it, the way I remembered it was arms at rest. That's something I remembered. I mean, that's something I used to remember this murmur situation. So what I did was arms at rest means ARMS at rest. So this is AR would be aortic regurgitation, MS would be mitral stenosis. So I would just remember like at rest means like diastole, and at work would be systole. So that's how I try to remember it. So you don't have to bother remembering the systolic types. You just remember aortic regurgitation and mitral stenosis is at rest, arms at rest. That way you would remember the two diastolic murmur types and then you would remember the other systolic types. I mean, these things are very, very important when it comes to the exam because you are not going to just go there and you see a question and like bring up the whole pathophysiology of the heart and then think, okay, so this one this valve is going to open, this valve is going to close, and this and that. So no way. You will need as many as short versions, short forms, short notes or mnemonics or all sorts as possible for the exam, because sometimes some of the mnemonics just don't make even just they don't even make sense, but it'll just get the job done. It'll just get you to get through that answer successfully. So try to make your own mnemonics, try to make your own little methods of remembering. So this one I tried to, come up with something, and then I had to stick to this arms at rest. So that is something I use for murmurs. And yeah, and then we also have, I mean, out of these things, aortic stenosis was quite often asked. So one way that you can remember that is the symptoms, that it's pretty much clear cut. I think I saw it in Amadex or somewhere, a question that had like properly these three. And the answer was aortic stenosis. I'll try to find it and put it in the question discussion slides for next Saturday. So remember SAD for aortic stenosis. It's syncope, angina, and dyspnea. So those three are the classic aortic stenosis clinical symptoms. And in this, so like I said, arms, I would just write arms and see aortic stenosis is not at rest. So the murmur is systolic. So again, with that, there are certain things that you have to, additionally remember. So murmur, just for aortic stenosis, remember it's a crescendo decrescendo systolic murmur. And then also it's best heard at second right it should be intercostal space, and it radiates the carotid artery. Those are little things that you have to remember along the way while studying the basics. And like I said before, these are some of the complications of aortic stenosis. And like I said, they're very, very good at asking the number one complication. Just remember these things. And yeah, investigations would be transthoracic echocardiogram. And then medicine, we have calcium channel blockers, beta blockers with caution. And then you can also go for surgical repair. I think I might have gotten that from an RSCGP guideline or something. That's probably why I put RSCGP guidelines there. So what you can do is just type aortic stenosis RSCGP guidelines and try to read. Maybe I can just show you. What I would do is text stenosis and then type RSCGP. See these as you can, I hope you all can see my screen. I mean, if it's not clear, just drop a message saying, I mean, y'all can't see the screen. So RCGP guidelines, one thing I really follow and one thing I really try to rely on when it comes to resources is that not everything, but these websites that end with .au. So as you all know, when it comes to AMC, it's an Australian-based exam, obviously. So it's always better to stick to websites that end with AU, with .au. I mean, I know you all might find so much better, like evidence-based information from NHS or USMLE websites and all sorts, but try to stick to .au website as much as possible. So that's why I always go to RSAGP, and also always try to check the date. This one's from 2024 because there's no point in reading a whole article from 2003 or 2004. there might have been so many other changes by now. So this is a little article about aortic stenosis. So like I said, see, differential diagnosis of a systolic murmur. So you could just see the other ones. I mean, one good thing about these RSHAP guidelines is that most of them have very like comparison tables. They have a lot of, especially when you do pediatrics, you'll realize they have so many flowcharts, so many almost like ready-made short notes in that. I know they do also have like pages and pages of explanation and articles, but they also have good tables. So try to read these through and see there's a point that says aortic valve replacement is the only treatment that improves mortality in patients with symptomatic severe aortic stenosis. See, these things are very, very important when it comes to answering questions because they might ask, what is the type of management to improve mortality in patients? And then you would just, the answer is just clearly there. Aortic valve replacement. So, yeah, that is that. So, yeah, apart from that, ECGs, um, I would suggest you all to read the book ECG Made Easy for ECG studying. I think it's a USMLE book, but it pretty much has all the details that you all want to know. Uh, yeah, likewise, when you're preparing for AMC, you'll figure out that there are certain books that you have to go through for certain topics. Like I think I mentioned this in my orientation program as well. So I said there's this book called 100 Cases of Ethics for Ethics, and it has been the best book and the only main source for studying ethics for AMC exams. So likewise, this ECG Made Easy book it should come in handy for you when you're preparing for cardiology. So add it into your reading list for the cardiology week. Try to finish it before going to questions. Just go through all the important things. You can do it like within, 2 to 3 hours if you continuously finish off reading it. So these are some pretty basic points again. So you can just take screenshot or read it through. Yep. ECG essentials, tall R waves. You can see in left ventricular hypertrophy and then tall T waves in hyperkalemia. You can see U waves of T waves in hypokalemia. And there's another thing that maybe I have missed writing. There's T inversion in hypokalemia as well, and short QT in hyperkalemia. And also you could see short QT in digoxin toxicity. Something probably I forgot to type. So this long QT that they don't even bother to give an ECG. They would just simply use long QT in so many questions in the STEM itself. So that's why I said while you do questions, you realize what are the most commonly asked areas. So I would say I came across this long QT question a lot. So you could use this ABCD method. I mean, long QT, you could see long QT either in asymptomatic, like this, no specific problem, or you could see in bradycardic patients, or it could be that, so we are in ABC, C is congenital. There could be congenital problems in that patient, or you could also, it could also be due to drugs, a certain set of drugs. So I'll also tell you all a little mnemonic I remembered for this set of drugs. I think it was dash takes ACE inhibitors. Yeah, because I'll just try to write it here. I hope it's clear for most of you all. D would be disopyramide. A was amiodarone. Amiodarone was pretty repetitively asked for this amiodarone. Pretty repetitively asked for this long QT question, amiodarone. And S was indastetolol, and the H was very commonly appeared in psychiatric question. I mean, they would just combine a psychiatric question with this cardiologic situation, like a long QT, and then we would just be thrown away. So that's how I remember DASH. And in ACE inhibitors, I would just remember ACE as amitriptyline. And chlorpromazine. Chlorpromazine. And E was a pretty common drug, erythromycin. Yeah, I mean, that's how I remembered ACE. There was nothing for IE, but I just remembered like ACE inhibitor. So DASH takes ACE inhibitors. DASH was our disopyramide, imidazole, sotalol, and haloperidol. ACE inhibitors as amitriptyline, chlorpromazine, and erythromycin. And so I told you these little things are very important when it comes to remembering things because you're not going to be remembering these drugs in any other way. So best is to just, use little mnemonics and try to remember things. And we also have electrolytes that cause long QT. I will try to write it in another color. When it comes to electrolytes, what you should remember is these three, decreasement of these three can cause long QT. It's calcium, potassium, and magnesium. Just remember those four electrolytes. So long QT, remember A, B, C, D, E. A would be, it could be asymptomatic, B could be a bradycardic situation, congenital conditions, or drugs. For drugs, we will remember DASH takes ACE inhibitors, so DASH and ACE. And then also remember electrolytes. That would be calcium, potassium, and magnesium. That's pretty much it about long QT. And like I said, try to rate ECG made easy as well. All right, so let's get to hypertension. So again, for hypertension, John Mutaj tried to read this page 1056. It's just here. So this is all about hypertension. It's in PDF page 1056. So you would just remember that 90% of the time it would be just a primary hypertension, but there are also secondary hypertensive conditions that have been asked in AMC. You would find it in this table. See clinical features suggesting secondary hypertension. So it's always associated with the clinical feature that's not normal. So that way you can remember the likely diagnosis. So yeah, this is again a nice to know table. Yeah, again, these grades and all that. Just go through, just better to know the normal range. That way you know anything above that would be not normal and anything below would be hypotensive. And just a bit of causes of hypertension. It's good to know. Kidney and endocrine and I mean you could relate hypertension to all sorts of or almost all the systems. So just good to have a read through and know what has what. And yeah, these things are there. And now this is also again a like a common, I mean that's like not a common, but a question that had appeared in the past. So they would just, give you like a high BP situation of a patient with like no symptoms at all, zero symptoms, like a proper healthy individual with what do you say, asymptomatic individual, and then like maybe a young patient even. And then they would like along with the options they would give check the cuff size or like check the placement of the cuff. So another thing you should know about AMC is they tend to test your common sense. Like they tend to try to get the most simple answer out of you, the most obvious answer out of you. So you are here thinking deep into what would go wrong, maybe like a malignant hypertensive situation, or I mean, I don't know, like you would think so deep into the case, but the simple answer would be just correct the placement of the cuff. That would be the answer. So just keep those things in mind as well when you're studying things like major topics like hypertension. Just remember things like that as well. So that would be important. And we also, this is again, you'll find in screening, we will do it separately on another day, a topic called screening to cover. So, like, there have been so many questions asking a, an 18-year-old child comes to a clinic for her first ever checkup and all that. What would you check in this patient or in this child or in this 18-year-old individual? And they would give like glucose and then maybe like a vision check or thyroid, and along with that there should be just simply BP. So always know in Australia all people aged 18 years and over are meant to check their BP, and it's recommended to check frequently, like every 2 yearly. So those things are very important. You can't just remember all of that in cardiology. So maybe whilst going through these cardiology topics, you might have realized that it's not just the cardiology that you have to remember, but then also little points like, important things. So, like I said, normal BP checked every 2 yearly. Mm, this is a measurement for 18 years and older. Yeah, and again, this is a very important table that would come in handy. Okay, Okay, so this is the table I've been searching for because this just not only has antihypertensive drugs, but beta blockers and all sorts are used in various conditions. So I mean, I wouldn't mind even if you can take a screenshot of this or just remember the page in John Mutaj. It's PDF page number 1067. So it has been very important. This is a table that I printed. So now see you can see beta blockers and then you go down and down, you see the contraindications, especially asthma because AMC is very tricky to put you through an asthmatic child, and then make you want to select beta blockers somehow. So be very vigilant when it comes to contraindications like this. So yeah, that is there. And then ACE inhibitors, if the patient has dry cough, you would just avoid it. And yeah, and this is a very important pharmacological table that you would use. And then again, pregnancy and hypertension is again a very important topic. We'll talk about it in detail when we come to obstetrics because it's again a place where you have to remember drugs, name of drugs. So yeah, and then again, hypertensive emergency. Just write it down for further reading. Hypertensive emergency it's an AMC tested topic again, so you can just read this through. Treatment is with dihydropyridine calcium channel blockers, or or you can maybe use ACE inhibitors, or else sodium nitroprusside IV in an intensive care setting. And then also, if it's like a pregnant patient with a hypertensive emergency, you could go to magnesium sulfate. That's to reduce the risk of eclampsia and maternal death. That's for patients with preeclampsia. So I would say just read through and highlight the important parts. Oh, yes. Okay, so this is a very, very important chart. I mean, a diagram again. It's a summarized one rather than just going through this. I mean, it's a little too detailed. So this one, if you can remember at least the highlighted parts, that would be very, very useful. See asthma, when you can what you can use and what you can't use. Obviously, like we said before, beta blockers. And then in cardiac failures, what you can use and what you can use with care. Diabetes, hyperuricemia, pregnancy, kidney. I mean, if you can take screenshots of these things or just print it out or find this in John Mutaj page, PDF page 1072. Just remember, I've been saying PDF page because the PDF number differs. It says 1072, but the actual page number is 917. So, yeah, that's again the end of hypertension chapter in John Mutaj. Try to read the important points, try to highlight, and try to add them in your note. So I think I also added like a few important points in hypertension. So one of the things I told you, I just keep my notes very short. That way I remember almost all the things in my notes. So in hypertension, one thing that you have to remember is young patients. If the patient is less than 55 years, treat them with ACE inhibitors. If the patient is old, more than 55 years, treat them with diuretics. I mean, these two sentences I just said, you will find evidence-based questions in your AMADEX when you're doing so. yeah, you'll come across that. And then, okay, this is where I talked about pregnant and hypertension. For moderate hypertension in pregnant women, you could go for methyl dopa. And then again, for emergencies, we can go for labetalol. And then there's malignant hypertension. For those cases, we can go for sodium nitroprusside, IV, again, IV labetalol, or hydralazine in pregnancy. You could go for malignant hypertension situations. And then these are the things that, like, little things that you have to remember rather than remembering so much, all the classifications, degree one, degree two, more than that, these little points are golden. So try to remember them. Again, for renal impairment, we could give ACE inhibitors or angiotensin receptor blockers. And it's another good to know point is that all hypertensives can cause a postural drop. So um, for that, you can do conservative management like increase sodium and water intake. And also you could just give medical management like fludrocortisone. And then another thing to remember is if this also has been an AMC question. So if a migraine patient comes with hypertension, you can always give beta blockers. So yeah, that's again another important thing to remember. But try to read the hypertension chapter from John Montage. It's again page 1056 in the PDF. So yeah, I hope you will find more interesting and important areas while studying that, reading that. And this is a little, we can't call it a miscellaneous topic, but it has been coming in AMC in the past. So again, aortic dissection, that is blood filling into the inside layer of the lumen of the aorta. So again, I remember this as ABC. When it comes to aortic dissection, I would remember it as ABC. There could be a atherosclerosis. I mean, that is what happens, atherosclerosis, and the age matters, old age. And then high BP, B stands for blood pressure, increased in BP. And then C, I would remember as connective tissue disorder, Marfan's. So you will think why, like, I'm specifically mentioning aortic dissection, like Caesars, when we have so much more to talk about in cardiology. But you will realize when you do questions that in AMC, some of these sections are very, very repetitive. So pay attention to those things. I mean, otherwise, anybody could just sit and read through the whole John Mutaj and say, okay, I'm ready with cardiology, I can answer anything. But no, you don't have to do that. What we are trying to do is just guide you through the important topics so you all can do your own reading and own studying and own preparation before the question class. So, yeah, blood filling into the inside of the lumen, that is that. So, and also aortic dissection could be due to trauma. It's like a sudden tearing, like a chest back pain, and you can have tachycardia. So, yeah, what now? Aortic dissection, the most common area that people have asked questions through was the investigation. So, one thing they would do is they would ask, what is the initial, like the first line, what did you do first? Then always go to chest x-ray. Then you would see mediastinal widening in the chest x-ray. And then there's CT scan. And then after chest x-ray and after you see a mediastinal widening, you would then go to CT scan. And then in that CT scan, you would see a double parallel aorta. So, and then those are the, like, this is the flow chart. We are going step by step, but if the question is asking confirmatory, what is the investigation? Like, what is the confirmatory investigation? You would always choose transesophageal echocardiogram. So always remember these important things. Uh, First line, and if they ask next, and then if they again ask confirmatory, those things are very, very important. When it comes to the question line, always make sure to at least highlight even in your brain to see what to what side they are directing. So remember this part for aortic dissection. It's very, very, very important. The investigations, and then when it comes to management, you would want to remember that type A, the ascending aorta, you would want to go for emergency surgery, and type B, it's descending aorta, you could go to medication and monitoring. And if in case if the patient is symptomatic, you would go with the endovascular aneurysm repair, EVAR, what you call it. And then we are pretty much at the last miscellaneous topic. So yeah, I'll just not give a long break, and I'll try to finish the seminar a little early because it's pretty late for me at my end. It's past 12, like 12:30 almost, so I don't want to hang on until like 1:30 or so. So I'll try to not give a break and finish the discussion a little early. So yeah, we have pericarditis next. So again, in that we have the basic, the common clinical features like pleuritic chest pain, and then you would also see chest pain when lying flat and tachycardia. And then for this, the investigations, we would just go for an X-ray to rule out others. And then this is a point where you have to really remember that ECG, you could properly differentiate MI and pericarditis. This is something that really happens in AMC. They would mix up the question directing to MI and pericarditis both the way, and they would give ECGs. So one way you could find is that in pericarditis, you would see diffuse ST elevation. It's just all over. In I mean, if you just read that AMC made ECG made easy book. I mean, all of you must be already knowing that chart of knowing inferior MI, lateral, anterior, that chart. So there's like a proper method, proper order, right? But for pericarditis, the ST elevation is pretty diffuse. So that's the main way I differentiate pericarditis and MI. So yeah, again, for management, you would give aspirin and NSAIDs. And this is another way I would remember the elevation. Just try to remember the arc, how it is. That is another way I would differentiate pericarditis and MI through the ECG. So yes, that is, I just had to go through a pretty quick brush through all the cardiology, the main cardiology topics. I mean, I believe we also need another little discussion. We'll try to see if we can arrange something before Saturday. If so, we will definitely share it on the group or in at least the topics, because when it comes to cardiology, we also have to discuss about the valvular part, um, and the vascular parts as well. But these topics that we went through today are the pretty straightforward um, cardiology topics that would come up in AMC questions. And with that being said, I think I showed you all how to use the AMC handbook, the MCQ handbook. So try to do those questions before this Saturday as well. They are in page 252. If anybody couldn't take a screenshot of this, try to take a screenshot of this because it's from 3.70 to 3.85. That's just 15 questions. Try to do those cardiology questions. So, and what I believe is what's most important is not trying to get those questions right. I mean, just trying to understand the question. And even if you get it wrong, trying to understand the explanation and trying to learn something through it would be the most beneficial one through doing these handbook questions. Uh, then again, with that being said, I would like to say the handbook would be a little outdated, could be not aligning with the most recent guidelines. So I would say always just type on Google, just like I showed before, just like I showed earlier, type whatever the disease and then type RSAGP. That way you could, try to find the latest guidelines, I would say. And um, I just made a little homework or like a to-do list because I would say in AMC, it's mainly about what you give, about what you do. So I feel like we could have hours and hours of discussions, but then that'll be totally pointless until you sit down and you read or you do questions. So I that's why I want to keep the explanations short, keep the slide number of slides short, just tell you all what to do, where to read, what the topics are, and what are the important things. And if you all have any doubts, you all can ask on the group. But the amount of time you all are spending with yourself, the with you and the books and the papers and the questions and all of that should be more. So in a day, if let's say in a week, should give like good 90% of time for self-studying, or let's say at least 80% of time for self-studying. And then the rest of the 20 or 10% or 15% should be for a discussion or like, all of that. But timely when it gets closer to the exam, I would say it would differ. When it gets closer to the exam, you would give a little bit more time for discussions and question discussions. So this is a little to-do list I made for this week. Um, so try and read the John Mortage book. I'm going to share it on the WhatsApp group. I do have the PDF. I'll get it to my phone and send it on the WhatsApp group. So yeah, try to read all those topics. It's on the index. I mean, you can follow it through the index and do the AMC handbook cardiology questions like I showed before. It's three, sorry, it was 3070 to 3085. Try to do all those questions and whatever that comes up, try it on the group or bring it for the next day's class. And Amadex, I mean, I would say Amadex is a pretty good, pretty reliable question bank out of all because I've done two types. I've done M plus X and Amadex, but I found Amadex. I'm not saying it's directly the exactly like the exam questions, but I would say pretty much not similar, the closest. The closest Q bank I would suggest for AMC would be Amadex. So try if you wouldn't mind, I mean, if you have already booked the exam, I would say subscribing an Amadex monthly or 3 monthly or 6 monthly or whatever the thing that you would want to get would be definitely would be helpful. So try to get that. If it's like maybe you could do that. You don't have to do it right away. Maybe you could do that after like a couple of weeks of preparation. You could get that. But if you want to go ahead and go, but get it because then it'll be helpful after finishing a specialty for a week. You could just do Amadex. So do that. If you have access, try and do the Amadex cardiology questions. And then, yeah, like I said, read RSAGP guidelines for anything that's unsure. maybe the handbook, maybe Amadex or anything. And one good thing about Amadex is they also provide you with the links, especially Amadex follows RSEGP guidelines, so that way it's very convenient. It's in the same, you're in the same page, Amadex and our study guidelines. So anything unsure, just go to RSEGP guidelines. And then something I wanted to mention was med bullets. So I know we not all of us might have time to sit down and write notes and shorten these big study areas. So I would suggest med bullets as a very convenient um, resource to find to get like all ready-made notes. So this is a, I think it is, yeah, this is a med bullets, what do you call, a note that I have downloaded from the internet straight away. So this is my little note for valvular disease. I didn't have to make one because it was pretty like summarized. I don't think even if I sit down with a pen, I would be able to do it as much as they've done. So see, they have aortic stenosis, they have the etiology, the murmur type, and the comments. So like I said, see, it's again sad. Mm. And then mitral regurgitation, tricuspid, all those things. I mean, it's always good to know a little comparison, and a table would be the best way to know that. So this one I specifically open to show you all how med bullets work. I think I do have the, I think, yeah, arrhythmia, med bullets. Yeah. So like you can see, it always comes up with a little, I hope you all can see my screen. If you all can't see, just please comment on the chat. So yeah, so yes, you'll see the question, a little introduction on what we are reading. So we are here about ventricular arrhythmias, and then you do have the symptoms, the epidemiology, and then you have types. And I mean, sometimes it's a little too deep, but then you have like a very shortened, easy to read note, ready-made note through mid bullet. So that's something I wanted to tell you all. It doesn't have to just be cardiology, but anything mid bullets is has come in handy. This is pericarditis, I think. Yeah, like I said, it comes with a question, and then it has a little summary. Comes with epidemiology and demographics, which we won't be needing. Most of the etiology is also not necessary for us, but sometimes you just have to know. See, most common cause of pericarditis would be viral. So that is something it's good to know. And then these associated conditions, my God, associated conditions are very commonly asked area in AMC. So whatever the disease you want to know, study, just write a little note in the corner with associations with that. Like, especially when you study pediatrics, gynecology, obstetrics in the future, you will know all these diseases. They really tend to ask associations in future. You'll see Downs, this and that, so it will come. So associated conditions, and anatomy is obviously not necessary for this exam. Presentation you would want to know because that's how the question will come. And then I would say diagnostic, it's most of the time it's diagnostic and treatment, most of the time. So it's always good to know. And even that in diagnostic and treatment, it's very essential to know if they're asking next, or if they're asking the best or the confirmatory or the gold standard or the like. Yeah, it's very important to know that, because see now, confirm the diagnosis. Likewise, in med bullets, they have clearly given that. And then they give you a list of studies that you want to do, and then they also give you differentials. diagnosis and treatment, like we discussed before. It would be an essay. Yeah, it's pretty much detailed, but you won't be needing all of these things. But I think it saves a lot of time. Let's say it wouldn't even take what 30 minutes to read this, or let's say you could give 30 minutes to read this, but if you were to read from a textbook or a huge article, it would take longer. So if you are running short of time, if the time you can give for a day to study is very limited, I would suggest you study things through med bullets. That way you can make your studying the theory time faster. So I think a couple of med bullets notes saved because I couldn't make notes for everything when I was studying. So yeah, that's pretty much the basic structure I wanted to put you all through in cardiology. So I would like, and also the last thing, obviously, share your doubts on the WhatsApp group. I mean, for me, it was really helpful the fact that I discussed with a little group uh, that also had same intentions as me, and they were not in the same timeline as me, but I mean, we adjusted. Some days I had to wake up at 3 or 4 just to adjust for Zoom discussions with them, for them to be easier. So likewise, you have to adjust and find a set of friends that are like study mates that are equally giving in as much as you are ready to give. So yeah, that way. And also I would really like if our group chat could be active every day, at least like if we can discuss 5 questions in there, it will be so helpful because and if everybody can be interactive, that would be really, really beneficial. So yeah, that's pretty much it about it. I mean, I really wouldn't want to take a lot of time uh, of yours and then keep on going about things that might even just not register in your brains, but rather I would just give you all a structure and let you all work through it. So yeah, I'm not going to take a break. I would just end it soon, end it earlier. And if there's any questions, feel free to ask on the group or feel free to ask from me. Uh, Maybe related to the way I studied, maybe related to notes or related to this cardiology topic, anything we discussed. Again, I'm saying when I was studying, I had to cut and chop and erase my own notes so many times because the guidelines kept changing, because the concepts I thought were right, the first line drugs I thought were right, along the way I figured they were not that. So it's pretty confusing because it's not just knowing medicine, it's not just knowing the symptoms and diagnosis and treatment, it's knowing what's given first in this country, it's knowing what test would they do first in this country. So it's pretty confusing because we all from different backgrounds, we all have practiced in different countries. So what's very, very important for this exam is knowing the Australian guidelines, knowing what they do here. So try to find as many as Australian resources as much as possible and try to make your notes and build the theory through that. So yeah, I hope you all gain something important from this lecture. And feel free to ask any questions. Even now, if you all have anything, just you can pop up and ask on the chat, the what it is, the Zoom chat. And if not, you all can feel free to ask on the through WhatsApp from me. So yeah, thanks for joining, and I hope you all learned something through this. Thanks.